Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Good morning, everyone, and welcome to the Codecast podcast. My name is Terry Fletcher. I hope everyone's having a great day today. Today, I wanted to get into a topic that I've been wanting to for a while. And with Medicare and some of the commercial plans now saying that once you've received that HHS money, we're going to go back and now we're going to do our oversight and determine if you should have get it or not. We are going to be auditing to make sure that it was spent the right way and, you had patients or you are a practice that deals with the COVID situation. And they put that in later. So, you've got orthopedic practices that got this dump in their account on April 10th, just like many of you did, of money. And now they're saying that you had to in some way see COVID patients. And then in the next line, they say something to the effect that, every patient is considered a COVID patient until they're not, which I just find ridiculous. So what I wanted to get into, because it is heating up for fall, specifically payer audits. And what I wanted to talk about were 10 ways you can avoid an audit. Now, I've done a lot of research on this. I've also sent and read a couple of articles. I've posted articles on this, and you've probably seen on my blog in the last couple of weeks how to stay out of fraudulent situations. And remember, I hate that F word, fraud. I hate it. But it's not your perception of what that is. It's the payer's perception. And you have to be careful because what they think could be bad faith or inappropriate billing practices could possibly contribute to you having to give back some money and maybe even penalties, etc. But as new technologies progress, more and more payers are actively deploying AI capability systems, and this shift is now producing more audits of physicians than ever before and directly contributing to higher rates of denials. And you're probably already seeing that, even though we were promised this great windfall when telehealth kind of took over during this pandemic. Audits take time and resources that you, quite honestly, don't have. You want to be compensated fairly for the work that you're performing and do what you do best, providing quality care for your patients. So when it comes to avoiding an audit, there's a lot to consider in every situation, and every situation is unique. Not only do I audit for payers, including Medicare, but I also audit for my clients, and some of you know that because I audit for you. And so I want to make sure that you have at least 10 options or 10 tips, if you will, that you can put in your compliance manual and make sure that you can keep doing what you do best. And again, that is seeing patients. Now, these tips are just professional opinions, not only of mine, but things that I have found by reading different articles, looking at things that I've seen trusted colleagues post. I've seen some things come from certain investigators from HHS, retired or current, where they will give lists. I've seen things on the OIG website, and this is kind of a collaborative effort. So everything that comes into play, and also when I audit, what I look for. So these are definitely just some information or some insights, I should say, instead of tips of what you can do to avoid an audit. So number one is understand your data. Are you an outlier? Is your physician an outlier? Is your practice an outlier? Don't be afraid to ask your coding and billing company if you outsource. Run a report. Ask them to run a report and have them compare you to other providers of your specialty. Differences between you and your billing and that of national averages can be due to inappropriate coding or insufficient documentation. It also could be a loss of revenue in the future if it hasn't already. The first thing I do when I have a new client that is asking me to evaluate their practice, and I get a lot of those lately, had one cardiology practice say, can you evaluate because we actually want to sell it or possibly merge with another practice? And I said, sure, let's take a look. So we looked at their AR, and they weren't billing for half the things that they could. They were missing codes on their cardiac cath. They were missing services on their interventions. They were billing only what Medicare said you can bill, and they weren't even considering what some of the commercial plans were allowing. And they were missing all kinds of things on peripheral vascular services. And so understanding your data and realizing and understanding a specialty, I should say, and realizing what you can code for is huge. I have an orthopedic practice that didn't realize that if you do a debridement for an open fracture, you can actually code for that in addition to the fracture care. And they said, no, that's bundled. And I showed them where it isn't bundled, where it is something that you can code in addition to with a modifier, and it's a specific CPT code. So understanding your data is really important first. Number 2 is know your denial rate. What is your rate of denials? If you don't know, this could be problematic. And I'm not talking about your rate of collections over your billing amounts. I'm talking about your denial rate. And then what are your denials? You can learn a lot by looking at your rate of claims and what your denial rates are on that claim scenario. And more importantly, why aren't you getting paid? And so I've also seen some of the payment posters in practices, even when payments are posted electronically, where they don't look at line items that have been denied. And so they just write them off. They just say, well, that payer doesn't pay for that. Well, why not? If you're coding for anything and reporting anything to an insurance payer, you're expecting to get paid, not hoping to get paid. If you're hoping to get paid, that's to me like throwing a spaghetti noodle against the wall and hoping it doesn't fall off to see if it's done. Don't code or report that way. So your rate of denials is very important. You can learn a lot by looking at that. Overuse of modifiers is number 3. A common misconception is that your claims won't get paid unless you put a modifier on it. And I see that a lot where certain modifiers are appended almost all the time, such as 25 and 59. These modifiers should only be used if certain criteria is met. Unnecessary use may land you in an audit. I've seen it. So your physicians say, well, I should get paid for that. Well, you need to back it up against the National Correct Coding Initiative. So the NCCI edits that say this code should or should not be paid with this code. There's also something called the MUEs. So that's where how many times can you bill a certain service per day and how many units can you have. And they call those medically unlikely edits. And so you need to know that and not just slap a 59 modifier every time. The 25 modifier is also overused. And I think I see this overused the most when you're dealing with preventative services and then a problem-oriented E&M service. And I think I'm going to podcast on that because that's become such an issue and nobody's reading their CPT book definition. And there are times when it's appropriate to do it, but there's a lot of times, I would say more often than not, where you shouldn't do it. And so we have to really take a look at that. Number 4 is time is money, and this is a big one because time-based codes are scrutinized heavily. And when we get into the 2021 E&M, which I'm going to be doing a couple of webinars on coming up here soon, you're really going to have to look at that because time-based codes, a lot of the payers are doing the math. If you're billing a lot of level 5s and you're basing it all on time, which start on an established patient at 40 minutes and on a new patient go up to 60 minutes and higher, you're going to have to prove that if you build, 15 patients, that you actually can prove that I was in the office for 15 hours. And so you have to be careful about that. Did you submit claims for an excessive number of hours in a day? And not just to one payer, but cumulatively. So this is where you can get into some serious audit trouble, and time has to be really looked at. I have several clients that I audit for that they're always putting time in, and they're always putting in 50% or more counseling, which in 2021 won't be a factor. But right now it is, and I'm seeing that no counseling information, only the phrase that's the drop down, basic cut and paste that you find in CPT, but then there's no information on why you'd need to have that discussion with the patient. Why did this have to be timed? Because without the time, and this is something I always do with my clients, I say, okay, with time, yeah, you met this code, but without time, you're only at a level 3 or 4, something to that effect, so that they realize that if their time-based codes and billing was ever questioned, then they're going to have a really tough time supporting it. And so time is money, and meaning that you have to support it if you're using it, and you have to be careful if you're using it. Number 5 is do it right the first time. Don't try to experiment when you're sending in documentation and billing to see what gets paid and what doesn't. This will set up red flags with payers. I actually see this with a couple practices. We'll try to send it in and see if you can get paid. Don't do that. I mean, you want to really make sure that you have plan information, that you have contract information, that you have national coverage or local coverage policies so that you understand. Do your research, do your due diligence, find out if something will get paid, and try not to experiment on claim submission. That is a red flag for sure. Next one, document it, all of it. Most important is your documentation. Remember, you've always heard if it wasn't documented, it wasn't done. You could end up not getting paid for the service, and everything from the completeness of what was documented and how it's phrased to simple things like just a signature line or a closeout, even if it's electronic signature, is going to be important. If you're doing smoking cessation, if you're doing advanced care planning, anything like that, you must document it. You can't just submit a code for it and then not see that it's part of the documentation that they might check on you for. So you have to make sure you're documenting it. And next year is going to be a challenge when we get into 2021 because of some of the history and exam issues that they're going to allow flexibility on. So now we get into number 7, where the patient is and where you are. So it's been a challenge through telehealth and dealing with Incident 2. Billing for services that are considered Incident 2 still have certain requirements. Now, obviously, during telehealth, a physician has to be accessible, has to be available, and I actually have them invited to the platform that the patient is dialing up on for an audio and video service. So that is something that's really tough. I try to get offices not even to go there during the pandemic, but some of them are. But if you're on a vacation, if you're making rounds at a hospital across town, or if you are somewhere other than physically in the office space as where the mid-level provider is also seeing the patient, or if it's a nurse visit where your medical assistant is, this is an issue. This is a possible audit issue, and it could be an intent to defraud the system issue. So when we get back to or during in-person visits, make sure that your Incident 2 rules are very tightened up and that they are very compliant. Otherwise, you could run into some definite issues. Over and under coding is the next one. So this is number 8, and we talk about over and under coding. Under coding means the code billed for is less expensive than the services documented, and over coding, a code billed for is more expensive than services documented or at a higher level. They're actually both improper representations of rendered services and could flag you for an audit. Whether you're billing level 2 codes, all of them, or all level 5s, it's still inappropriate coding. I tell this to physicians all the time when we have training sessions where they say, well, I'm just going to bill level 2, 3 then. Well, that's not going to help you because you are up against your peers, up against your same specialty, and they're looking for bell curves. They're looking for a good mix of patients because let's face it, not every patient is a level 5, not every patient is a level 2. That's why level 2, 3, 4, 5 all exist, because we have patients from the gamut of the bell curve, meaning that we have some that are sicker than others, some that are dealing with chronic conditions but status quo, and then some that are dealing with less systemic and less acute issues, which would be the lower levels. So you have to understand that over and under coding is a huge topic. When I do some defense work and I do some work for legal work for attorneys, one of the biggest things when I'm in a deposition, and I'm always, I would say 90% of the time on the physician side, there's 10% where I do some payer work. I am seeing the attorneys say upcode. They love that word. And so overcoding is a serious concern and an audit flag. Number 9 is unbundling. Okay, this is where my head spins around. You may find it more lucrative to bill for multiple CPT codes, even when a single or more appropriate code would suffice. However, this is a huge red flag. That points to intentional forms of overcoding. So staying abreast of the latest codes, CPT codes used by your specialty helps. So it would be like trying to code for a coronary injection, right and left, plus a catheter placement, plus an imaging code instead of just coding a heart cath, let's say, that has one code that represents everything. I know that in orthopedic, for example, one of the things that was bundled inclusive a few years back was a chondroplasty. So that shaving of that knee during a meniscectomy, when they're taking out the meniscus or taking a part of it out because it's torn or ripped or needs to be repaired. And so they said it's inclusive because it was all the time. So every time you would see a medial meniscectomy or a lateral meniscectomy, then you would also see a chondroplasty, which was more of an incidental shaving in that area of those tendons. And so the CPT book included that service within a meniscectomy. And I still see physicians saying, well, put a 59 modifier on it because I want to get paid. You can't do that. If the code itself says that it is inclusive of other services, then you have to use that code. So be careful with that, otherwise it can be a problem. Then you have services that are not just inclusive based on the code, but they are considered inclusive based on the edits. And so one thing that comes to mind, that actually I don't agree with this edit, but we have to follow it because it's part of what Medicare says, for example. And that is, let's say that we are in the middle of a heart cath and all of a sudden the patient has an arrhythmia, or what we call the computer of the heart wants to reboot, means there's an abnormality on that side. Well, the physician has to put in a temporary pacing wire so that they can keep the heart beating. That's actually inclusive or bundled. Now, I don't agree with that bundling, but we have to know it. And that's why I wanted to bring that to your attention. If you go back to what we were talking about at number 1 on this list, understanding your data, you need to understand what is and what isn't inclusive within your specialty. What can you code for? What can't you code for? And be very mindful of that and make sure that anybody who's also a coder in your practice or coding with you also understands those bundling guidelines. And then the last one is obsolete coding. Coding and billing professionals, you're responsible for keeping up to date with the changes of code sets such as ICD-10. They change all the time. They actually, for the first time in history, had a change on April 1st to add in ICD-10 codes for COVID. So you need to understand what's there. The World Health Organization and also CDC, they give input as well. And so a lot of those codes come from those organizations. Current procedural terminology, that's the CPT code book. And so, I use the professional edition, but you should always be updated on your CPT codes. That's from the American Medical Association. And then there's also your HCPCS book. That's the Healthcare Common Procedural Coding System. That's from Medicare. And you need to understand that those changes are at least annually. And sometimes when it's new technology, they'll put it up there on their website as being updated quarterly. But it's really up to you to make sure you understand. I still have people asking me why they can't get paid for a consult for Medicare patient. When did Medicare do away with consults? 2010, 10 years ago. And I'm still getting asked that question. So if you want to avoid an audit, keep these things in mind. Understand that it's important that you are also doing your due diligence, that you're being proactive, and that you are doing everything you can to also protect your physician and protect your practice. So if you do these things, you will be good to go when it comes to hopefully staying out of the hot seat when auditing season comes, and it's coming. It's already on my calendar. It's already on many auditors' calendars, and you will see payers now saying, we're going to go back and see if we can get some of that money we gave you. And so they're going to be looking for sure. And remember, E&M codes, they are the most sensitive of all the codes that seem to be something that Medicare and the other payers want to tackle. So hopefully you were accurate and correct in what you did from a telehealth perspective. So my personal tidbit this week, I'm very excited. My wine club is open again. Yay. So we still have to practice social distancing. So we don't have to wear masks, but we have to be at least 6 feet apart from each table. But you can be at a table with people you know and that you're comfortable with. So we're excited. And we're getting together this week on Wednesdays. So that makes me happy that things are opening up and I actually get to see my friends after not seeing them for 3 months. So, well, okay, I'm being a little bit dramatic. How about 10 weeks? It's still too long. We've done Zoom calls and things like that, but that's not the same as just being able to sit and talk with somebody. So hopefully you're seeing some of that interaction and that you're getting to have some personal time with people and that you're getting out and about if it's allowed in your state. And if you are not compromised in health, remember, if you're sick or if you're feeling sick or if there's any concern that you have, continue to stay at home, continue to take your precautions and do what's best for you. But I'm excited about at least some things starting to open up. So everyone, make it a great week and a great day. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.